So it's my pleasure to introduce the next moderator for the afternoon plenary presentation block. He is a longtime organizer of this symposium, Dr. Victor Fujimoto, who is a professor of obstetrics, gynecology, and reproductive sciences. Vic?
First of all, thank you to all of you who are staying around for the final session. It's been a long day, but an engaging one. And I'm going to introduce our next set of 4 speakers and ask all of them to come on up and take a seat at the panel here. The first speaker will be Jessica Anusin, and our second speaker will be Yelena Mustra-Rakic. Our third speaker will be Colleen McCourty, and our final speaker will be Maya Vijayaraghavan. Please give them a warm welcome of applause. And let's see. The first speaker is Jessica, and we'll go ahead and set things up, and the podium is yours. Thank you.
Hi. So I'll go ahead and get started. My name is Jessica. I'm a second-year medical student here, and this is a presentation on a project I did over the summer with a team at the Department of Public Health and UCSF. So some background for this project. As we know, diabetes, especially when uncontrolled, can result in significant morbidity, but there's also a number of racial disparities that impact diabetes outcomes. For example, non-Black Hispanic individuals, non-Hispanic Black individuals are more likely to be diagnosed with diabetes and 2 times more likely to experience complications from diabetes. Similarly, Hispanic adults are 1.7 times more likely than their non-white, Sorry, give me a moment, guys. Hispanic adults are 1.7 times more likely than their non-Hispanic white counterparts to be diagnosed with diabetes. And these disparities also exist in San Francisco. As you can see in this graph, which looks at the age-adjusted rates of hospitalization and ER visits due to diabetes, in 2016, Black and Latinx individuals are more likely to experience adverse outcomes related to diabetes. So how can we address these disparities? So for one, a team-based approach to diabetes care has been shown to be rather effective. For example, the chronic care model has shown proven benefits in glycemic control, and it's also important to address social needs such as food insecurity to advance equity in diabetes outcomes. Yet research on food vouchers and food prescriptions and their impact on diabetes management is still emerging. So that leads me to the aim of this particular study. So the aim of this study is to evaluate a team-based care pilot program supplemented by food vouchers to assess its impact on improving diabetes control for Black and Latinx patients with uncontrolled diabetes. So in 2022, participants were recruited from 2 clinics in the San Francisco Health Network, and the eligibility criteria for this project was people who identified as either Black/African American and or Latinx, and those with uncontrolled diabetes, which was defined as an A1C above 8. So this project was a 6-month chronic care pilot model, and there was a care coordinator who worked on managing the patient panel and also did appointment reminders. They also received support in terms of scheduling a visit with a pharmacist or nutritionist, and they received smoking cessation and transportation services if they were interested. And all participants received food vouchers specifically for produce or groceries totaling $160 per month. So the data sources for this project were quite varied since it was a mixed method study using qualitative and quantitative data. We collected voucher usage data, baseline and final surveys from our partner ESF, and we also did semi-structured interviews and reviewed the electronic health record. So a bit more information on the interviews I mentioned. So program participants were offered interviews after the program. The interview guide was developed by DPH and UCSF team members and also pilot tested to ensure acceptability, and interviews were conducted by team members. The interview focused on 3 main themes: program reflections, food voucher use, and diabetes self-management. Example question from the guide is, tell me about your experiences in the program, and participants were probed on what was the most beneficial or most helpful part of the program for them. So a bit more about the data analysis and outcomes of this project. For the quantitative data, we had two main outcomes, A1C and voucher redemption rates, and we specifically did descriptive statistics and a two-sample t-test for our continuous variable A1C. On the qualitative side, we looked at program acceptability and satisfaction, as well as voucher usage, and interviews were transcribed and analyzed with deductive coding, and themes and representative quotes were identified. So I'm going to discuss more on the results of this project. So the participants in the study, we had 45 participants, and about 40% identified as Black or African American, 53% identified as Latinx, 47% identified as female, and 53% identified as male. The majority of our participants spoke either English or Spanish, and the average age was 57. The max age was 84, and the minimum age of participant in the program was 35. So there were three main themes that emerged during the interviews, and in the next couple of slides, I'm going to deep dive into each of these, as well as the sub-themes that accompanied them, and as well as share illustrative quotes. So the first main theme is the program factors impacting health behaviors, and that included sub-themes such as teaching leads to actions, which refers to ideas that program participants implemented knowledge for the program in terms of managing their diabetes. There was also the sub-theme of two-way teaching, which reflects how program information sort of included the participants' experiences and felt like it matched their own ideas about what diabetes information and care should look like. And a better understanding of diabetes refers to participants leaving the program feeling like they knew more about how to manage their diabetes. And a quote that really demonstrates this is, "I've learned a lot from my nutritionist as far as just trying to get more motivation to cook my meals, because I notice when I buy my own food, cook my own meals, that plays a big role in keeping everything under control a lot more than if I'm ordering or something like that." The second main theme was this idea of developing new relationships with food. And so one of the sub-themes within that was learning to substitute better, which speaks to the idea of choosing a healthier option instead of completely removing an item from the diet. The other sub-theme was a positive change in shopping habits, which sort of refers to the idea of how food vouchers made the process of shopping for food a more enjoyable experience for participants. And the last theme, accessibility of healthy food, really speaks to the impact of food vouchers and discussing, of course, about how healthy food became more accessible through the program. An illustrative quote of this phenomenon is, "Having the vouchers helps because when you're on a limited income, it's hard to buy all the stuff that's good for you. Those vouchers, they really helped a lot in going into the grocery store, knowing that I could get, the things that I needed." So one of our last main themes, establishing and maintaining collaborative diabetes care, really speaks to the idea of the impact of a team-based approach in diabetes management. So the first theme within that is collaborative care, which refers to the idea of multiple providers working together to manage a patient's diabetes. The second one, patient engagement in care, refers to how a patient is involved and engaged in their diabetes care beyond their health appointments. And the last one, positive relationship with care team, really speaks to how patients felt connected to their healthcare providers. So this quote was said by a patient who was talking about what they feel like when their provider calls them, and they said, "Just knowing that they're monitoring that they care. They tell you that they care, and that's another thing. They show you how they feel. I like that." So moving into some of the more quantitative results from this project. So this table looks at the voucher redemption rates from the program. So about 73% of the grocery vouchers were redeemed, and 64% of the produce vouchers were redeemed. And it's important to note that only 9% did not use their vouchers for 3 consecutive months. We also looked at A1C values pre, during, and post-program. So the baseline A1C for our participants was 10.4, and this decreased to 9.67 by the time the program ended, and this was a statistically significant decline. So some final takeaways about this project. So there was a decrease in A1C after participation in the pilot, but it's also important to note that participants enjoyed being in the program. They gained knowledge in regards to healthy eating and diabetes management, and utilized food vouchers to purchase groceries that met their dietary needs. There are some important limitations to address as well. So this was a small cohort because it was a pilot study. There wasn't a comparison groups, and analysis reflects the available data in the electronic health record. Labs at the start and end of the program were not required. And it's also important to note the continued impact of COVID-19 on healthcare engagement is difficult to quantify in this study. But beyond this pilot, food vouchers and robust team-based care can improve diabetes outcomes. It's also an avenue to increase racial equity in diabetes care and address social needs. And beyond diabetes, it's important to advocate for the inclusion of food pharmacy and prescription food vouchers and healthcare delivery models. For example, the results of this pilot has allowed the program to expand to 450 patients across San Francisco. So thank you for listening to this presentation, and you can contact me at jessicanewson@ucsf.edu.
Good afternoon. I'm Jelena Muštra-Rakić, postdoctoral fellow here at the Center for Tobacco Research at UCSF, and I'm grateful for the opportunity to present my work here today. The title of my work is ApoL1 Risk Variant Associated with Prevalent Stroke Disease in African American Current and Past Smokers. Before I start, I would like to say thank you to all the wonderful people who helped me conduct this research and to the funding entities. Every 40 seconds, someone has a stroke, and every 3.5 minutes, someone dies of stroke. This makes stroke the 5th leading cause of death and leading cause of long-term disabilities. However, not all people have the same risk for stroke. African American Black people, or Black people, how I'm going to refer to this population throughout my talk, have the highest risk for stroke compared to all other races. Still, one of the well-known and well-established for decades now risk factors, cigarette smoking, was only recently evaluated in this population. And what was found is that Black smoker compared to non-smoker have 2.5 times higher risk for stroke. And when we compare to the reported stroke among the white people, for example, where is 1.5, it is much greater. So how can we explain this? And this is after we adjust for traditional risk factors. So in order to understand this, we look back how many of traditional risk factors were established. And greatly what we know came from the Framingham Heart Study. And this is a great study, long-term, ongoing now for more than 70 years. And it helped us define traditional risk factor, including smoking. However, this study was done on residents of this small town Framingham in Massachusetts, and this study has its limitation. So 100% of the population were white. So we cannot generalize that, those findings, and it's possible that because of that we missed to include some risk factors that are not present among the white people. So now I will tell you a story about apolipoprotein 1, or ApoL1. It was actually discovered here at UCSF. And this ApoL1, it is part of the high-density lipoprotein, HDL, which we know as being this good cholesterol because it removes excess cholesterol out from the body. What is also known about ApoL1, it is that protects against African sleeping sickness, which is caused by this parasite, Trypanosoma brucei, carried by this cute fly that you can see here. And 10-ish years ago, it was discovered that there is not just this one sequence, G0 sequence, how I'm going to refer it, this reference sequence of this gene, but there are actually 2 genetic variants, G1 and G2, how I'm going to term them. And these variants are clinically relevant. And they are, if you are a carrier of these genetic variants, you have extended protection against African sleeping sickness, but you also have higher risk of kidney disease, and several studies found that you may also have a higher risk of stroke. And now you wonder who are the carriers of these genetic variants. In the United States, roughly 50% of Black people carry these variants, while in other races, it's very, very rare. So now we know that Black smokers have uniquely high risk for stroke, and they have high prevalence of these ApoL1 genetic variants. What we do not know is the role of these genetic variants in tobacco-related stroke among the Black people. So the research question is whether carriers of these genetic variants are more susceptible to tobacco-related stroke compared to non-carriers. In order to answer this, we conducted cross-sectional study on 513 Black adults that were recruited through the UCSF Lipid Clinic over the 20 years. And here we wanted to answer the question, what is the association between smoking? And smokers were defined as ever smokers, meaning current and past smokers combined, and never smokers, and how it relates to the stroke, so having history of stroke, yes or no, and whether this is modified by the presence of these genetic APOL1 genetic variants. So in order to do this, we had to do the sequencing, so we had to assess the APOL1 genotype status. And so we did the sequencing of this APOL1 gene, and then how the status was assigned for each participant. So because each of us gets 2 copies of the genes so one from the mother's side, one from the father's side, so you can be either homozygous, so having 2 identical genes copies, or different, that would mean you are heterozygous. So if you were homozygous for G0, you were assigned to have reference genotype. If you were heterozygous for either G1 or G2, you were assigned to have 1 risk allele. And if you were homozygous for G1, for G2, or heterozygous for both G1 and G2, you were assigned to have 2 risk alleles. And here on the right side, you can see the chromatograms of some of these genotypes. Now when we know the status, so we divided participants in 2 groups. Those who had the reference genotype were the part of the reference group, and those who had 1 risk genotype or 2 risk genotype, part of the risk genotype group. And the results. So our median age of our participants was 58, roughly same percentage females and males, and 42 were ever smokers, so current and past smokers combined. Then we quickly wanted to, then we also wanted to see what is actually percentage of this risk genotype in our population. And we actually found that 54% of our participants had this risk genotype, so either 1 or 2 risk allele. And then we looked, now we divided our participants in 2 groups, those with the reference genotype and those with the risk genotype. And then we wanted to see whether there is difference in the prevalence of stroke, depending whether you are ever and never smokers in those groups. And what you see among those with the reference genotype, you do not see significant difference in stroke between the ever and never smokers. However, when you look among those with the risk genotype, you see significantly higher prevalence of stroke among ever smokers compared to never smokers. Then we looked at the strength of this association by doing logistic regression. And when you look overall, you do not see a significant difference between the ever smoking and stroke. The same goes when you look among those with the reference genotype. However, when you look among those with the risk genotype, you see significantly greater odds, almost 3 times higher odds for stroke among ever smokers compared to never smokers. Then we did exploratory analysis. I'm saying exploratory because we knew we do not enough power to find significance, but we were wondering whether we can see some trends. So we looked deeper into this genotype to see whether there is difference in odds of stroke if you are carrier of 1 or 2 risk allele, and if you are a smoker. And what we see is that with the increase of the risk allele, there is increase in odds of stroke among ever smokers compared to never smokers. So in conclusion, we can say that carriers of APOL1 risk variants are more susceptible to tobacco-related stroke than non-carriers among Black people. And it seems that the carriers of 2 APOL1 risk allele may be more susceptible than the carriers of 1 risk allele. And the implication of our findings is that screening for these APOL1 genetic variants may help identify people at higher risk for tobacco-related stroke. And also this finding could provide some insights and some directions that could help identify targets for treatment and prevention that could help reduce racial stroke disparities. Thank you, and I'm looking forward to your questions and comments.
Hey everybody, thanks for hanging in the warm weather in here. I'm Colleen, I'm a resident in internal medicine. I'm excited to build on this idea of the importance of collaborative care today and to tell you about my work with the No One Waits study, looking at the role of the pharmacy team in facilitating access to hepatitis C treatment. How does this, okay, all right. So why talk about hepatitis C and why now? Hepatitis C is a public health threat. Through its effects of cirrhosis and liver cancer, kills more Americans than most other reportable infectious diseases. It's also a disease of really extreme health disparities. But on the other hand, we have a curative treatment that's available, and the treatments that we have these days are simpler, more effective, rapid, and really well tolerated than what we've had in the past. And so, taking all of this together, the idea of eradicating hepatitis C as a public health threat is a real possibility. Unfortunately, if you look at the trends of what's actually happening with hepatitis C infections right now, things are not moving in that direction. This is CDC data from 2021 showing that acute hepatitis C cases are actually increasing, and initiation of treatment of hepatitis C is not increasing to keep up with these increasing risks of infection. Since we know that this is a disease of disparities, these treatments, are needed most by really vulnerable patients who are often the last to access new treatments that arise. We can see these disparities within our own city here. In San Francisco, people who inject drugs are a very small minority of the population, but make up the vast majority of hepatitis C infections. We also know that nationally and locally, Black and African American patients really bear an outsized burden of hepatitis C infections. And looking at this geographically in our city, this might not be surprising if you've lived here for a while, that a lot of this is really centered in neighborhoods where a lot of vulnerable people reside, which really, I think, leaves some opportunity and need for directed interventions in these neighborhoods. So thinking about why this is such a hard problem, like why if we have these treatments are we not connecting people to the treatment we need, it's actually a really complex problem. I've put a lot of factors up here that play into why it's hard for patients to access hepatitis C treatment, and for the purpose of this talk, I'm really going to focus on systems level factors that make this difficult, specifically those around prescription drug coverage for hepatitis C treatment. These medications are expensive, they can often have preventive co-pays for patients. Often they require complicated prior authorizations and dispensing through specialty pharmacies, which puts up a lot of barriers for vulnerable patients who don't always have access to transportation or a phone or an address. And so that's where this NOW study comes in. It stands for No One Waits study, and it's a single-arm clinical trial looking at the acceptability, feasibility, and effectiveness of a community-based point of diagnosis hepatitis C treatment model that was located in the Tenderloin neighborhood in a community gathering site in our city. So this trial was really designed to provide comprehensive care to patients who are infected with hepatitis C, starting from screening all the way to follow-up after treatment. So patients who were enrolled in this trial were offered screening, and then after their results disclosure, were offered to enroll in actually same-day treatment initiation, which is a really unique and kind of important part of this study. And the way that was possible is that patients were offered donated study drug by the drug manufacturers and were allowed to continue on that medication until insurance authorization was obtained through their own insurance, or to continue on the free drug for the duration of treatment. And throughout this whole project, patients were cared for through longitudinal collaboration with an integrated pharmacy team, which was really critical to the study. So the pharmacy team in this study was really involved from the very start of patients enrolling. Starting with prescription of the medications, the pharmacy team would dispense a free 2-week starter pack of drugs to patients, and then work on anywhere from getting them covered by insurance all the way to medication delivery. So verifying their insurance, filling out prior authorizations for patients, and then once the prior authorizations were accepted, working on enrolling patients into copay assistance if needed. And then finally, like I was saying before, a lot of times these medications had to be dispensed through specialty pharmacies. The pharmacy team would actually coordinate pickup of the medication from specialty pharmacies and directly dispense them to patients in the community site where the study was conducted. So looking at the demographics of the patients that were enrolled, 87 participants were enrolled, and their demographics really closely matched those of people in San Francisco who are affected by hepatitis C. This trial was mostly men, mostly unsheltered patients. There was an overrepresentation of Black and African American patients compared to the San Francisco population in the trial. And most of these patients had ongoing injection drug use and income below the federal poverty line. Since we're talking about insurance coverage, it's also important to just note the insurance coverage of people here. And because we live in San Francisco, most patients actually had insurance. The vast majority of them were managed Medi-Cal or straight Medi-Cal, and then some were Medicare patients, and others were either uninsured or out of network in the Kaiser and VA systems. And this is kind of our main results slide, is that, within this patient population, the pharmacy team in this study was quite effective in getting patients enrolled into insurance-covered direct-acting antivirals. So the goal of the study, at the outset, patients were given a free 2-week starter pack of medication, and the goal was really to transition them to their own insurance-covered medications after that 2 weeks. And over 70% of patients were able to do that in this study. I will point out, though, that there, were a number of patients who required significantly longer than that, and these patients were really dependent on this free study-provided drug to get through to their own insurance coverage. But ultimately, almost 90% of patients were able to transition to their own insurance-covered medications before the end of treatment. There were a number of barriers that came up during this study. I think kind of the most interesting one, sort of around the use of specialty pharmacies and how specialty pharmacies relate to kind of a unhoused patient population. So these specialty pharmacies, in order to dispense the medication to our pharmacy team, required patient consent, typically by phone. And this was actually a major barrier in kind of the timeline of patients receiving their insurance-covered medications, because a lot of people in the study population didn't have reliable access to a phone where they could consent. So stepping back and thinking about some of the lessons that we learned in this trial about how to address barriers to accessing treatment for hepatitis C for patients, we know that the prior authorization process can cause major delays in treatment initiation, really for any patient with any medication, but especially in this patient population who don't necessarily have access to like an address or ways of communication with the specialty pharmacies. And in this case, the free medication programs here were really effective in sort of bridging that delay between getting the medication, starting treatment and getting the medications covered. Also, like the insurance requirements for submitting prior authorizations are like not standardized, quite complicated, and the presence of a pharmacy team here really could help navigate insurance authorizations and those barriers for patients. Like I said, also like the pharmacy was really helpful in bridging delivery from specialty pharmacies to unhoused patient populations. And one thing I didn't have a ton of time to get into, but the pharmacy team here was really helpful in connecting patients to copay assistance programs for these medications. They didn't often have very high copays, but they were enough that in an under-resourced population that this was a major barrier, and having the pharmacy team enroll patients in copay assistance, I think, allowed a larger population of patients to get started on treatment than may have otherwise. And so I think my big conclusion from this, and something that's come up a lot of times today, is really the importance of collaborative care and really harnessing a lot of different kinds of providers and caring for vulnerable patients. And I think in this study, it was really successful because of the role of direct partnership with pharmacists who were able to really connect patients to the medications that they need. So this is my acknowledgement slide. I want to thank my mentors, Megan and Jenny, who are both here today. And I especially want to call out the pharmacy team in this study who made all of this happen. One of them, Diana Ung, is in the front row right here. If you want to ask her any questions later, she's a wealth of knowledge about hepatitis C pharmacy. And also our funders, Gilead, for donating the drug required for the study.
Hi, everyone. My name is Maya Vijayaraghavan. I'm really happy to be here to present to you the Leadership Academies to reduce tobacco use among people with behavioral health conditions. So I'd like to start by acknowledging our funding sources. This was funded by the Substance Abuse and Mental Health Services Administration and Robert Wood Johnson Foundation. And this work really was started by Dr. Steve Schroeder about 15 years ago, the founder and the inaugural director of the SCLC and the SCLC team, who's right there, if you want to just raise your hands, and is work from the last 15 years. We also had Jason Satterfield and Fan Shah, who provided support in the last few years, and Fan, who ran the statistical analysis. So tobacco really is a health equity issue. Tobacco use is concentrated among people with behavioral health conditions. You can see in this slide that people with behavioral health conditions have 2 times the rate of tobacco use compared to those without. And within the population with behavioral health conditions, rates are much higher among people who are living below the federal poverty line, who are people experiencing homelessness, who've had criminal legal system involvement, who are sexual and gender minorities and racial ethnic minorities. And it is of the 500,000 deaths yearly from tobacco-related illness. It's a staggering rate. 240,000 of those are among people with behavioral health conditions. So to address this stark disparity, the SCLC pioneered this model called State Leadership Academies, where they worked with state leaders to use a results-focused approach to help states break down silos in addressing tobacco use, facilitated cross-sector collaborations, encouraged states to use a data-driven approach to set goals and targets to reduce tobacco use among their behavioral health populations, create ongoing opportunities for collaboration, and using this model, which was based on the performance partnership model, achieve reduction in tobacco prevalence. So the performance partnership model is really meant for states to assess where they are now, where do they want to go in terms of tobacco prevalence, how do we get there, and then how do we know that we're getting there. So there was a 3-pronged approach, starting with a summit. This was a facilitated leadership convening of 30 to 40 state stakeholders from different sectors. And the goal of these leaders were to develop an equity-oriented action plan that was really focused on moving the needle in education systems, policy, and data in reducing tobacco prevalence. After the convening of the summit, the SCLC team provided technical assistance for up to 3 years to help these state leaders and partners move their work forward. And part of this effort was also really providing community-level education through continuing education webinars and actively updating resources on our website and providing these resources to state partners as a venue for shared learning. So just to give you an example of what these strategy committees are, so for example, education was around educating providers through adapted or new curriculums. Systems was really around helping states introduce cessation interventions into routine clinical care. Policy was addressing legislative or judicial administrative policies, clean air, for example. And data was really around identifying data sources that address the needs of behavioral health populations. So this work was really not done under the framework of research. This was work that was done under the framework of service. And we used the RE-AIM evaluation framework to see how well we did. This framework has come up several times today. And what the states really did was set targets for themselves on where they would like to be 5 years from when they participated in the academy. They used the Behavioral Health Risk Factor Surveillance Survey to assess their baseline tobacco prevalence among their behavioral health populations. And then we looked at their 18-month progress and the 5-year progress. The 5-year benchmark is where they would really like to be in 5 years after starting this work. We also asked states to complete 6 to 12-month progress surveys. For the analysis, we used linear mixed effect models to really see whether state prevalence declined after participating in the academies, and then we did thematic content analysis of the qualitative data. I will say that these analyses are preliminary. We just started working on this and really happy to share these findings. So what are some of the approaches? So for example, Mississippi for education really focused on training the Department of Mental Health staff on integrating tobacco use within their workflows. For systems level, they did a formal request for Medicaid expansion to cover cessation services. For policy, they targeted smoke-free policies in casinos, and for data, they looked for different data sources to support their work. Rhode Island, for example, added the Department of Corrections in their working group as a group that was missing from these discussions. Systems included providing billing and reimbursement information for any providers trying to provide tobacco cessation care. From a policy perspective, they tried to work on increasing pharmacists' prescriptive authority to provide tobacco cessation medications. And then they also administered a provider survey. States chose different approaches. So let's get into our metrics. So REACH, we were able to convene leadership academies in 24 states between 2011 and 2023. We specifically targeted states with high tobacco prevalence. Other measures of REACH, we were able to train around 28,000 behavioral health providers during this time frame and conducted 127 webinars and facilitated collaborations with 2,000 organizations. The table here really represents the cross-sector collaboration and the representativeness in the academies. You can see that 90% of the participants in these leadership academies are coming from disciplines across public health, mental health, and substance use, healthcare payers, and the government, and 10% from tobacco control. So this is looking at the decline in tobacco prevalence among people with frequent poor mental health, which is a category in BREFIS. You can see that most states had a decline in their tobacco prevalence among people with frequent poor mental health after participating in the summit and participating in the leadership academies. And this was a mean decline of about 1.2% per year after enrollment. This is among people with heavy drinking, and you can see that most states had a decline. There were some states that were going in the opposite directions, and you'll see that some states only have 2 time points because they just recently had their summit, and we're capturing the last 5-year time point. But this was a decline of around 1% per year. So what does this really mean in terms of numbers and from a population prevalence? So assuming the population at risk is the population living with frequent poor mental health, and when you're looking at the prevalence of smoking, you're looking at the number of people with poor mental health who smoke over the population of people with mental health. Taking New York State as an example, there are 1.5 million people with frequent poor mental health, and a 1.2% decline is around 18,000 people. And assuming this decline is causally linked with participating in the academies, that is an assumption that we need to look at. This is around 18,000 people who stop smoking per year. So what are some of the implementation successes and challenges? Again, pulling up some examples from some of the states. For example, New York's success, 21 out of 23 New York State mental health facilities had smoke-free policies. The challenges was really around extending Medicaid benefits for nicotine replacement therapy coverage. Massachusetts had a wellness approach to integrating behavioral health and tobacco use within Mass Health, their main health insurance, their main Medicaid health insurance. But they also experienced substantial communication barriers. There were participants in the summit that initially convened that had later left. That was making it hard to move the work forward. So in terms of maintenance, some of the barriers, and this is something that we actually experienced most recently in Tennessee for a leadership summit, where the political climate and the priorities of the state government does play a role. And if this is not a priority, even though there might be people within the government willing to move it forward, it makes it really hard. Leadership and staff turnover is something that I think is universal for all the work that we do with communities. And then just lack of data among the specific populations that we really want to work with. Successes are cross-collaboration across state departments in healthcare and really building catalytic leaders. So in conclusion, leadership academies are an effective model, we think, to engage with state partners and stakeholders. They lead to catalytic leaders who can address tobacco use. There is a positive correlation between decline in prevalence and participating in the academy. And if we think that this is an academy effect, the potential people that may be impacted may be quite large. Sustaining momentum is a challenge, but these convenings can reinvigorate efforts and offer opportunities for shared practice. So I'll stop and really want to share deep gratitude for the SCLC team and also our state partners and Steve Schroeder for initiating this work 15 years ago. Thank you.
Okay, great presentations. Thank you so much. All 4 presentations are now up for questions, and so who's got the mics and who has questions for our speakers?
First of all, thank you all of you for your fantastic presentations. And thank you for the work that you do. I had a question for Colleen. I was wondering, with the pharmacy team, did you experience any issues with loss to follow-up for patients who didn't have homes or didn't have phones? And if so, how did your team, or what strategies did you use to prevent that? And then the second question I had was just a practical question of how you negotiated for donated medications from the manufacturers.
Oof. Can I pass the mic over to our team pharmacist, actually, to tell you about maybe some of the barriers she encountered here?
Hi. Can you repeat your first question again? I'm sorry.
Yeah, the first part of my question was if you experienced issues with loss to follow-up for patients who didn't have homes or didn't have phones. I work as a case manager myself, and it's really hard to connect with patients who don't have homes or phones. So I was wondering what strategies you used for that.
Right. Well, our setup, we didn't get a chance to really go through like our entire setup. We have a really strong team of like a social worker, like a case manager, people that are doing outreach. So in terms of the pharmacy team, we relied on them on site to really help to make sure that they came back for follow-up. So our role at the pharmacy was really just to work with the team that was on site to do that. And yes, there may have been a couple of people lost to follow-up. I'm just trying to look for Megan. Right? Do you want to talk about that a little bit?
The main point, and I appreciate you as a caseworker, is really working with people who are boots on the ground. And so the NOW study, we are really leveraging a long-standing relationship with 15 or so community organizations, many of them who have daily or near daily contacts with the people that end up being participants in our study. And so it truly is a community, a village approach to making sure people can come back. And I'll just add that all of this is done through a real harm reduction philosophy. So if people don't come back when they're scheduled, we don't penalize them, we welcome them.
I think there was a question about how do you convince Big Pharma to donate drugs?
They asked us to apply for funding with them, and so I think that, in short, we really leveraged that momentary positional power that we had. And while they did cut our budget significantly to do the research, we held strong on making sure that the study drug was donated. So it was a critical component of that, and I'll just say I think it's going to be really impactful this moment in time for policy advocacy related to ensuring that these drugs remain accessible.
Other questions over in the far side?
Hi, my question is for Jessica. Is that right? I'm wondering if participants in your study offered perspectives on the use of or receiving very specific aid, vouchers, et cetera, on food, when really, versus receiving, for example, direct cash benefit.
Yeah, thank you for that question. I don't think I really got to hear specifically how participants felt receiving benefits specifically for food, but I think a lot of participants did appreciate the fact that it was for generally just groceries instead of being reduced to just produce. But I think there is a lot of interesting research on like cash benefits, but I wouldn't say in our interviews that we touch on that. But thank you for such a great question.
Other questions from the audience? I have a question for Yelena. Yelena, very interesting study.
Thank you.
What can you propose? Why do you think APOL1 variants predispose to a higher risk of stroke in tobacco smokers?
Well, so of course, mechanism is still unknown. So what I am thinking, based on what we so far know, is that they are more susceptible to that because, so these variants were found to, for example, to accumulate more in necrotic core of plaque. And what we also know is, for example, that if you are exposed to some inflammatory conditions, is that these APOL1 risk variant their expression is higher. So the idea why these people may be particularly susceptible to this tobacco-related stroke is because tobacco is promoting inflammatory state in the body. So we are thinking that this APOL1 variant increase more in this necrotic core, and we are thinking that that might be one of the mechanisms promoting the plaque rupture and maybe leading to the stroke.
Thank you very much. Any other questions? Over in the corner there.
So on that same study, I was just curious. I know that the APOL1 literature in the kidney disease specifically has looked at attributable risk and how much of the difference in, by race ethnicity there can actually be attributed to APOL1 differences, and it's a very low percentage compared to things, the social factors that we know are associated with the social construct of race. So I was wondering if you could say anything about actually the attributable risk associated with this with respect to disparities in stroke.
So, I mean, in how the study was defined, so we control for as many factors as were available, and so we cannot control for all the factors, but what we can say is that in this study, so the population was among African American Black people, so that was at least limited and kind of removing some other differences that are present among different races. And then, yeah, but we did not have like all the like socio-economical status, access to healthcare and those kind of the factors, but the population was African American people who self-identify as African Americans. So yeah,
Hope that answers the question.
Any other questions? We're about out of time here. If there are no more questions, I would like to go ahead and introduce Dr. Hal Collard. He's the Vice Chancellor of Research here at UCSF and Professor of Medicine and Health Policy, and he will be providing closing remarks.
Thanks, guys. Do you want to stay up here? You can go sit back down too if you want to. Hi, everyone. I'll be very quick. I want to make a few just key observations or comments and observations. First is to say thank you so much to Renee, Tung, the whole group that organized this. I know there are many, many of you here. It is such a privilege to be here as part of this really important meeting. So I think this was with my introduction. I don't know if I'm Vice Chancellor for Research here. Did you say that, Vic? So I want to just, on behalf of the research mission, just be very clear that this type of work is central to our mission. I want to commit to you that we will do all we can to support this type of work. And so again, thank you for including me. I was here most of the day. I want to say to all the speakers and all the poster presenters how wonderful the work was. I think is really high-level research, which shows how this field is really healthy and growing and leading here. That's great to see. I have my list of names. I'm going to reach out to all of you who presented because I have some questions for you, mostly about how we can help support your work better here. So I really appreciate hearing from you, so hopefully you'll answer my email. One more thing I just want to say about research in health equity and anti-racism. You know, walking in here today, I walked past the statue of Hippocrates. And, you know, one of the things we learn in medicine, I'm sure across healthcare, is first do no harm, which is at least attributed to Hippocrates. So, again, to share my own personal perspective, I think you hopefully agree with this. There is harm every day from health inequity and racism in healthcare. This work really needs to be central. These considerations need to be central to all research. But we also need to do more research specifically in how we improve health equity and address racism systemically and otherwise in the work that we do and the mission that we have. So again, I just want you to know that that's how I view this, and that's how I'm trying to work with Renee and Tung and all of you in supporting this. So thank you all very much. I think before you go, Tung has one or two final comments to make, but I want to be available to all of you and help support you, so please don't feel like you can't reach out and let me know what we should be doing better. Thank you.
I want to continue my talk from before lunch. No, just kidding. So actually, you know, we do this thing with stakeholder engaged work that's very subtle, but it's not that subtle. And that is we bring our stakeholders, let's say our communities, together with the decision maker, right? And then we hope that rather than me, the researcher, transmitting the information for our stakeholder to our decision maker, policy makers, we let them talk to each other, right? And that's actually what Hal's here for. Basically, he heard everything. He knows what's happening. And I think he's thinking, like, what kind of structures can we implement that improve this work in all the aspects that you mentioned, just like the leadership academies, sort of involving the decision maker at the point of the interventions. If you didn't have enough health equity and anti-racism, there's more later today. The School of Nursing early stage researchers are having a session, including projects on early infant formula supplementation, trauma-informed approach for adverse child experiences, impact of COVID-19 among sexual and gender minorities, bottled water consumption and bisphenol urine concentration, and substance use among men who have sex with men. It is going to happen right after this at 3:30 across the street in 521 Parnassus, room 1111. There's a flyer if you're interested in doing more. But I really want to thank you all for being here. This is our first session back in person in 4 years. You made us feel really good because you were here, you did your science. It's wonderful. There was one thing I would say. to finish us off with, and that is we need positive reinforcement. I just can't say how hard it is to do this work. If you even listen between the lines of all the pain that occur on all these slides today, I mean, there's a lot of pain there that we're trying to fix. And we need community and we need positive reinforcement. I need to do this to get up every day to fight the same battle over and over and over again, and so do you. And community building is actually really important, and I really appreciate the fact that you were all here. And then I'll finish by saying one thing, which is, and this is, the sociologists are going to be all over me, but there's a study that I'm looking at Jen, she's giggling. There's a study that I love that I have no idea how they did it, but they claim that in social change movement, you only need 3.5% of a population to be engaged to have it happen. In other words, you don't need 50% of the people to be on your side. You don't need 20% of the people to be on your side. 3.5%. At UCSF, we have 30,000 employees, trainees, yeah? So 3.5% is about 1,000. 300 people signed up here. So if you can just get one more friend to participate in the revolution, we can have it. Thanks, see you next year.